After the fetus, I'd be looking for the cord and the meiotic fluid and placenta. In cord, if I see a single umbilical artery, then it may be associated with trisomy 13, 18, triploidy, and monosomy X. And if I see a corax cyst of the cord, that may also have association with trisomy 13 and 18. If I see polyhydramnios, then it may also be one of the findings of the chromosomal abnormalities, but especially if there is marked IUGR, in which I would suspect that there should be oligohydramnios. In that case, if I see the polyhydramnios, then I am more suspicious of the chromosomal abnormalities. And similarly, marked oligohydramnios may be another indicator for the chromosomal abnormalities. After that, I'll come to the placenta, and I'll look for presence of any small cystic spaces within the placenta that would suggest a Swiss-Cheese placenta or partial molar placenta that has a typical association with triploidy, but it may also be associated with trisomy 18. Okay, thank you. I finished it in 15 minutes.
Thank you very much. Thank you very much. Since Dr. Zahid Pasha has been kind enough to give us a 5-minute bonus, I hope there are some questions that you want to ask him. I'd like to spend those 5 minutes in a question answer session. Is there any question? No questions? Okay, then a brief comment from my end. Usually a microcephaly and an IUGR are late problems. So if you find this happening in an early pregnancy, in a second trimester situation, then you're probably looking at an IUGR, at an aneuploidy. So that's just a small pointer. So these are generally things that become obvious around 27, 28 or around 38 week. So early problems are probably more significant. Thank you very much, Dr. Zahid Pasha. That concludes the first session. I suppose we'll be moving on directly to the second session now. Okay, over to you, madam.
Thank you, Dr. Durasabi. Now we commence our program with the second session, and that is Al-Zaim Al-Azhari University, Sudan session. The chairman of this session is Professor Dr. P.K. Srivastava from India, and I request him to please come to stage. And the moderator of this session is Dr. Niveka Zaya. He is also from India. Please come to the stage for the commencement of the session.
Good morning, everyone. So we just arrived to the second session of the day, and I think the first talk is of Dr. Mustafa from Sudan in ultrasound and renal transplant. He is a consultant radiologist at the Al-Zaim Al-Azhari University, Sudan, and has presented excellent papers at the national and international conferences.
Assalamu alaikum. Bismillah ar-Rahman ar-Rahim. I am going to talk about post-transplant imaging. I'm not going to speak about the preparation of the patient for transplantation, but we go directly for transplanted patient and see the complications. Sonography of the normal renal transplant. Ultrasound is the principal imaging technique used in evaluation of the transplanted organ. We need to have grayscale, color Doppler imaging, and pulse Doppler also is required. Also, we need to have power Doppler facility. Mainly, we look if there is a treatable renal or extrinsic cause to be treated. We look for if there is an immediate medical or surgical therapy to be required to save the renal graft. And third, we see if a renal biopsy is required for further diagnosis or not. First, we have to see to look for the surgical technique. This is the aorta and the common iliac artery. Usually, the iliac fossa is the site of the implant. There is anastomosis between the renal artery, transplanted artery, and the common iliac artery, and the renal vein also is transplanted into anastomosis to the common iliac vein. The ureter is transplanted obliquely into the bladder so as to make an artificial valve to prevent reflux, and the ureter is kept as short as possible so as to prevent necrosis. A normal grayscale of transplanted kidney should look like a normal kidney with renal pyramids and the renal cortex well differentiated. In post-transplant period, you may see a normal dilatation of the collecting system, which can be a normal finding. A normal graph on color Doppler imaging look like you can see the renal arteries and veins with different flow directions. This is color Doppler ultrasound obtained immediately after transplantation and shows a small fluid collection arrow. This is also an expected finding in immediate post-transplantation. The important thing is to measure resistivity index, which is the peak systolic flow velocity in the renal artery minus the end diastolic flow of this is divided by the peak systolic velocity, and this ratio is very important in evaluation of the transplanted graft. This is the peak systolic flow and this is the end diastolic flow in the pulse Doppler. Then we come to elevated cause of elevated resistivity index. This can be divided into parenchymal, vascular, and urological and technical causes. The parenchymal causes includes acute rejection or acute tubular necrosis and pyelonephritis. The vascular causes, these are renal vein thrombosis and hypotension, and urological causes include urethral obstruction, and last we come to technical. This is graft compression, for example by hematoma. Okay. In the complications of the renal transplant, this include parenchymal causes, or it can be divided into immediate, early, and late causes, later complications, and parenchymal, vascular, urological causes, and fluid collection, neoplastic complications, and iatrogenic complications. The immediate complications, this is the parenchymal cause of immediate complications. This is include acute tubular necrosis, rejection, hyperacute, and accelerated acute or acute rejection. The early complications, this occurs in the first 4 weeks, and this include acute rejection, and the late complication of parenchymal causes, acute rejection, chronic rejection, and cyclosporine toxicity. Vascular causes, immediate complications which occur in the first week of transplantation. This is renal vein thrombosis or renal artery thrombosis. In early complications of the vascular causes, renal vein thrombosis, and in late, renal artery stenosis. Urologic is this urethral edema. This is an immediate complication following transplant, and urine fistula or urinoma, and uterine stricture as a late complication. Fluid collection, this is maybe due to hematoma in acute or immediate phase, and or abscess formation. Urinoma usually occurs in the first 4 weeks, and lymphocele is a late complication as fluid collection. Rare neoplastic complications, this is reported as skin malignancies and lymphoma, which occur always late. Iatrogenic causes, this is post-biopsy, hemorrhage, renal arteriovenous fistula, and pseudoaneurysm. This is an abscess formation following transplant anterior to the transplanted kidney. One of the early or late complications. And this is also hydronephrosis due to a lymphocele here. This is hydronephrosis in a transplanted kidney. This is a case of chronic rejection. As you can see here, the kidney is shrunken with poor corticomedullary differentiation. Acute tubular necrosis, also following transplantation, and this is one of the most complications that can occur due to edema and necrosis, but this will be reversible. As you can see here, the pulse Doppler, there is biphasic flow in the renal artery. Also acute, this is an acute transplant rejection with edema and loss of the end diastolic flow in the pulse Doppler of the renal artery. This is very severe transplant rejection with backflow in the, with very low diastolic flow in the renal artery. This is renal